Welcome back. This is the second part of our lecture on fibroids. So we were talking about the possible presenting complaints. It is most important to remember that many women may not have any symptoms. Okay, even if they know that they have fibroids, they may not be having any symptoms. Okay, and a lot of women, they do not know even that they are having fibroids. Anyways, so the most common presenting complaints are, if there are any, it's abnormal uterine bleeding and infertility. But when fibroids grow to big sizes, they can also cause compression or pressure effect on the surrounding structures, which can cause pain or discomfort. Okay, and they, because of these pressure symptoms, when they grow big, they can cause compression of the bladder, which can cause urinary frequency, for example, or even difficulty in emptying the bladder, so urinary retention as well, or bowel symptoms, for example, constipation, and the patient may need to excessively do straining during for bowel movements. Okay. So in abnormal uterine bleeding, what can be the pattern? It's usually heavy bleeding, heavy and prolonged bleeding. So that means heavy menstrual bleeding, right? Women may have intermenstrual bleeding, especially if it is submucosal fibroids, okay? But usually the main pattern of bleeding in abnormal uterine bleeding is heavy menstrual bleeding. Only submucosal, cervical, and intramural fibroids can cause heavy menstrual bleeding. Okay, why? Or abnormal uterine bleeding, because anything which is outside the cavity of the uterus, until and unless it is protruding into the, it is distorting the endometrial cavity, it won't affect periods. Okay, same is with infertility. So usually it is submucosal, cervical, or large subserosal fibroids if they are obstructing fallopian tubes. So subserosal usually do not interfere with infertility until and unless they are causing obstruction of the fallopian tube. Intramural fibroids, if they are small and if they are not reaching the junction between the endometrium and the myometrium, they may not interfere with implantation. But if they have a component which distort the endometrium, or if they are very close to the endometrial and myometrial junction, then yes, they can interfere with implantation of the embryo. Now, this pain and discomfort. So it may be depending on the position of the fibroid. For example, if it is in the anterior wall of the fibroid, what kind of symptoms we are more, what kind of symptoms do we expect to see more? It's the pressure symptoms on the urinary bladder anteriorly, right? If we say, for example, if it's a big subserosal fibroid which is causing compression on the rectum, then of course patient will present with backache, or she may present with constipation. Okay, so it depends on the position and size of the fibroid as well. And rarely, sometimes what happens, if it's a subserosal fibroid, because if it is pedunculated, it can kind of twist on its pedicle. Okay, so and it can cause pain. Usually fibroids do not cause pain until and unless they grow very big and cause pressure symptoms, or if it's a pedunculated fibroid and it has twisted. But there is one condition related to pregnancy which is called red degeneration of fibroids, which I'm going to discuss, which is a painful condition. As a general rule, if a patient presents with edema, right, with lower limb edema or gross varicose veins, please always take the patient as a whole, right? So the patient may be presenting to some other discipline, right, to some other speciality. But always think about pelvic masses. Okay, because if there is a big pelvic mass, which can be a big ovarian cyst, or it can be a big fibroid, or any intra-abdominal big mass or tumor, it can interfere with the venous return from the lower limbs, and as a result, what can happen? The patient may not notice this swelling in the abdomen, but they may notice the pedal edema, and then they may go to either cardiology. Yes, of course you will rule out other things, right? Like you, of course you will rule out kidney disease, liver disease, heart failure, or heart related issues, but always completely examine the patient. Okay, so that's just one of the reminders. Now, how to diagnose fibroids? Of course, we always take a history. we make a differential diagnosis based then on our general physical examination, on our abdominal examination and pelvic examination, which includes a speculum examination and a bimanual examination. And then I know, especially if it's a busy clinic, so we usually prefer to, instead of doing a bimanual examination, we like to jump straight on ultrasound. Okay, so if we are following a sequence, depending on how patient had presented, say for example, if she presented with heavy menstrual bleeding, then we can perform a complete blood count. But does that help us do the diagnosis of fibroids? The answer is of course no. Then we can perform, one of the options is perform a serum CA125, right? But it's a tumor marker which is very non-specific. So yes, we know that with fibroids, CA125 levels will be high, but they are not specific to fibroids, right? So yes, we usually do not do CA125, okay? So we are talking about how to diagnose fibroids, okay? So ultrasound. Now ultrasound, when you are telling me I'll do and perform an ultrasound, then you have to tell me what kind of ultrasound will it be. Will it be a transvaginal ultrasound or will it be a transabdominal scan? TVS is transvaginal, TAS is abdominal scan. Now, usually in gynae patients, we start with a transvaginal ultrasound, okay? If there is no contraindication, of course. So if transvaginal ultrasound, why? Because when a uterus is not enlarged in a normal uterus, which is not pregnant, that's a pelvic organ. That's not an abdominal organ. Okay, so that means that is below the level of the pubic symphysis, right? Upper margin of the pubic symphysis. So it's a pelvic organ. That's not an abdominal. And when does a uterus become an abdominal organ? When it's 12 weeks size. 12 weeks means 12 centimeter almost, okay, equivalent to a pregnancy of 12 week size. So even if we are saying this fibroid is big and it is, we will say 16 week size, okay, we usually don't say 16 centimeter until and unless we are talking about ultrasound findings. So if I performed a clinical examination on the abdomen of a patient and I felt a mass midway between the umbilicus, lower margin of umbilicus, and upper border of the pubic symphysis. So that's 16 weeks size, right? So I will not say 16 centimeter. So that's the just the terminology we use. I know that we are not talking about a pregnant woman, but we always, because we are in gynae, so we just always think about pregnant women as well. So if we think that it's a big fibroid, more than 12 week size, then we have to perform a transabdominal scan as well. Okay, and once we find like a big mass, then of course a mass, then rest of the abdomen should be scanned. Okay, and which includes, of course, it will be performed by a radiologist, not a gynecologist. So I have written it here. Serum CA125 is increased but not reliable and not used for diagnosis. Then, if a woman presents with infertility, okay, now this scenario is only for women with infertility, and if we think that she might have an endometrial polyp or even a submucosal fibroid, because sometimes if they're small, they can be even missed. Okay. So, and we also want to know the status of her fallopian tubes, whether they're open or closed. Then we can perform hysterosalpingography and hycosi, which is by the ultrasound. So HSG is by X-rays. Just go back to the lecture on infertility, and hopefully you will remember. But I want to tell you in relation to this topic is, if we have performed an HSG or hycosi, we can only see submucosal fibroids or endometrial polyps. Okay, we cannot see intramural fibroids which do not have a submucosal component or subserosal fibroids on these investigations. Okay, then hysteroscopy as well, because hysteroscopy is just putting camera inside the uterus, right? So we won't see subserosal fibroids. We will only see submucosal fibroids, or if there is intramural fibroid with submucosal component, okay, endometrial component. And then MRI. So especially one of the differential diagnoses of fibroids, we will talk about differential diagnosis, but that's adenomyosis. That's a condition, and sometimes, unfortunately, some women may have actually a cancer of the uterus, like a sarcoma, right? From the smooth muscle, there may be a sarcoma. So that's rare, good for all women, but sometimes that can happen. So MRI helps, but that's of course not the first line. So the first line diagnostic test for fibroids is ultrasound. Okay. So how does it look like on ultrasound? Now this is a very tiny one actually. I can, maybe when you come back to campus, I can show you other images. So see, all of this is the uterus. Okay, so this is normal myometrium. So it looks kind of grayish and small hypoechoic area. So actually sometimes fibroids can be tricky. Sometimes they can be even hyperechoic. Hypoechoic means less, like they are darker. Okay. Hyper means they are like bone, like whitish. Okay. Sometimes fibroids can be, so see this tiny one, that's the small hypoechoic area. Okay. Sometimes there can be mixed echogenicity, like there may be hypoechoic and hyperechoic, and sometimes there may be calcified. So whenever something is calcified, it looks hyperechoic, like whitish. Okay. So, and this is an MRI. So what do we see? So if this is the endometrial cavity, right? So behind the endometrial cavity is the posterior wall. This is the posterior. How do I know that this is the posterior wall of the uterus? And this is the anterior wall of the uterus. How do I know that? Because they have mentioned that your urinary bladder is here, and this is the pubic symphysis. So of course this is the anterior part of the patient. So this is the anterior wall of the uterus, and they have noted one big fibroid in the posterior wall, two smaller fibroids in the anterior wall. Now you can, just by looking at the MRI of this patient, you can actually imagine the presenting complaints, right? Or like what, so pain or pressure. Yes, she might have backache, she might have constipation, might be it is already pressing on the urinary bladder. Maybe this is small, but maybe, may or may not be, she might be having urinary complaints, right? So we can also already kind of guess, okay, what might be the complaints of that patient. Now differential diagnosis. First is adenomyosis. Remember, we have a separate lecture on adenomyosis, so we won't go into that detail. But adenomyosis is again estrogen-based disease. It's a benign condition. It's usually present in middle-aged women, and usually these women are multiparous, which means they already have a few children, and deep dyspareunia and heavy menstrual bleeding. So deep dyspareunia in history taking and heavy menstrual bleeding. And dysmenorrhea as well. Dysmenorrhea, deep dyspareunia, secondary dysmenorrhea, okay, deep dyspareunia and heavy menstrual bleeding. And endometrial cancer is a differential diagnosis, may or may not be less likely, okay, or less common. Leiomyosarcoma, it's a rare condition, but there have been cases where a patient was operated upon and thinking that it's a fibroid, but it turned out to be a sarcoma. So sometimes that also happens. Okay, I'll continue the rest in the third part of